So good morning and welcome to Grand Rounds. This morning we have three individuals who are going to present. Dr. Matt Bromwich, who's an associate professor in the Department of Surgery and a pediatric ENT surgeon here at CHEO. Matt completed medical school at Queen's and then following training in surgery, he was recruited here to the University of Ottawa. He has been prolific in research. He's well published, has acquired significant funding, and he's the inventor of several medical devices and holds 4 patents on various products in Canada and the US. His research is focused on delivering innovative and inexpensive solutions to improve healthcare. Anna McCormick is also an associate professor at the University of Ottawa in the Department of Pediatrics and completed her medical school at Memorial and then went on to train in rehabilitation and was recruited here. She's involved in a whole number of research initiatives, too many to mention. She's also currently serving as the scientific co-chair of the American Academy of Cerebral Palsy and Developmental Medicine, where she's leading a task force to enable the use of technology to optimize functional outcomes and participation. The final speaker is Dayre McNally. Dayre is also an associate professor in the department at the University of Ottawa in the Department of Pediatrics. He's an intensive care specialist. He completed his medical degree at Dalhousie, having previously completed a PhD at Carleton, and also went on to complete an MSc in clinical epidemiology at the University of Ottawa. His main research investigates the role of vitamins, including vitamin D, in pediatric illness. And he has an eclectic array of interests beyond that, mainly including exploring the potential of crowdsourcing, systematic reviews, predicting RSV illness, and pediatric tracheostomy. I think it's fair to say that all of our speakers are innovative in their approach to the work that they undertake. And not surprisingly, the topic for discussion today is building a pediatric innovation program here at CHEO. So I will hand it over to Matt to lead things off.
Amazing. Well, thanks very much, Dr. Duffy, for that warm introduction. And thank you all for being here and the opportunity, of course, to share something that we're all really excited about. This has been a fun, although challenging experience, as I think some of our speakers will tell you about. And I think the whole point of this innovation task force is to try and make the process of bringing good ideas to bear a little easier. So the theme is translating health technologies into care solutions. Now, I think I'm sharing the slides. Can someone confirm that? And I can't see you, so you have to say something.
Yeah, it's fine.
Perfect. And how we go about translating these healthcare technologies and bringing them to the patient bedside. Now, although this looks a bit like Ian McCluskey, it is not. It is Thomas Edison. I hope anybody laughed at that because I can't tell again. But you may have heard this somewhat trite sentence, which is there's a better way to do it, find it. I think, of course, we would all agree with that. I think the real challenge is once you've found your better way of doing it, how do you make people do it that way? And how do you change the system to start doing things like that? And that's the real challenge that we've encountered as physicians who often, at least we think, have good ideas about how to make things better. But then how do you implement that in a system-wide way, in a sustainable way, is really challenging. So our learning objectives will be to share with you some of the projects that are going on. We've kind of been calling them internal and external innovation. Really, it's all the same pathway. It's just about where you get on it. From an internal standpoint, Dayre will talk to you about the masks that he's been working on from the ICU standpoint and how that went. From an external innovation, how we bring in other technologies to the hospital, where Anna will talk about. And we really want this to be a somewhat inspiring talk that will help you understand how your own ideas could move through this process, where the roadblocks are, and if you know what to expect in terms of what the roadblocks are, you're much better prepared to deal with them rather than being discouraged. So we want to turn everybody possible into a CHEOpreneur, and my apologies for that term. We did just make it up, but it seems to fit the bill. And consider being involved in how to make this better so we can support CHEO in providing kids with their best life. So what we identified is that although doctors and clinicians and surgeons and everybody at CHEO may have great ideas, it's hard to navigate the pathway of bringing that to bear because it's complicated, sometimes challenging. Even if those challenges are small, there's so many of them, eventually it just snuffs out the spark of innovation instead of fanning it into a fire. So how do we address that? And again, fun quote, Henry Ford was 20 years younger than Thomas Edison. So this quote is actually a response to Thomas Edison's quote, where he was talking about finding a better way. Henry Ford said, well, all these people are trying to find better ways of doing things that shouldn't have been done in the first place. So there's no progress in finding better ways to do stupid things. And so, I agree with that. Like, not every idea is a good idea necessarily. So the process involved in filtering through the potential changes is an important one, and coming up with things that really do have the highest potential. And so it's not only facilitating ideas, but filtering ideas as part of this process. And so why does CHEO care? Well, I think there's some obvious benefits about how has technology improved our lives. Like Zoom, in pandemics has really changed things, and we made that change out of necessity very quickly. If we could apply that same urgency to some of the other things that we've been doing, I think would be really beneficial. And Anna will talk a little bit about this robotic walker and some other technologies that we're interested in. So we really want to speed up that journey. We know it's between 7 and 20 years to bring a new technology to the bedside. 20 years, of course, being on the long side, and it really doesn't need to be that far. And when you look around the country or internationally, basically Boston Children's is a great brand of being innovative. And why can't we do more of that at CHEO and become the Canadian equivalent of that? At the home of BlackBerry and Nortel in Ottawa, I think we really have the ecosystem available to us, and we could. In some cases, there's revenue opportunities. In some cases, there's cost savings opportunities. And really, at the end of the day, by creating this ecosystem where this can happen, it can really encourage the increased output of this kind of research and endeavor, which in the end helps our patients and families. It also aligns really well with the standard CHEO house. If you pick almost anything on there, you can make it better through the innovation process, particularly in terms of access. Think about remote clinics. That's a new technology-based innovation, and it certainly has improved access to my patients and probably all of yours as well. And so it's easy enough to fit this in. And so I think from a buy-in standpoint, everyone can get on board there. Charles Kettering was an interesting guy. And if you ever have a chance to read his biography, Sloan Kettering Memorial Hospital, a big cancer treatment center in the States. Charles Kettering was an engineer, not a doctor. And he invented the baby isolette, for example, and windshield wipers, and air conditioning, and all kinds of things. Anyway, his bit was you have to have a certain amount of intelligent ignorance to get anywhere. And what he meant by that was that if you know too much about how other people tried and failed to do things, you'll get so discouraged that you won't do anything. So being ignorant of all the problems and all the resistance you're going to encounter is sometimes useful. And if you reflect on your own life, if you think, well, if I knew all that was going to happen, I might not have even started. I'm sure we all feel like that somewhere. So again, our team is to try and educate you in the right parts and facilitate you in the right parts, but not scare you off, because it is a hard process, but it is doable. So with that in mind, we have actually starting to collect a big team of people across the organization to help. And that's because if you look at how Spotify, if you ever look this up, how Spotify organizes itself, it has these different silos of groups, but then they have cross-functional individuals, and then they have these guilds, which involve people from all over that aren't necessarily connected in any particular way, other than they're interested in a certain thing. In this case, innovation. So a lot of these people are across the organization and connected by their desire to help this process. So myself, Dr. McCormick, Dr. McNally, and Jim are the ones sort of trying to guide this process. And I'm so grateful for all of you participating. I did want to say on this slide how grateful we are of the support of Mari, who I saw was on the call, and Jason Berman from the RI, who's been very supportive of this. And and the rest of you that are participating, in monthly meetings, trying to help this move forward. It couldn't be done without you, and it really is so important to have a team working on this. And as a note, that's the thing that differentiates hospitals that do this from hospitals that don't do this. You look at research in universities, they have a big institution that does that, and hence we produce research. And if you look at innovation or translation and universities that are successful, like in Stanford or Boston Children's, they have big organizations that do that. And so it really is incumbent upon us to create that organization, that ecosystem, in order to enable this kind of output. So our vision is to create this ecosystem to bring these innovations, and other people have done this and are working on it, which is interesting. Everyone is starting to realize that this is the way forward, and that's true at Sick Kids, at Baycrest, as I mentioned, Boston Children's. And we've been working on something, this task force, but with an eye towards creating this committee and eventually maybe even a separate not-for-profit out of the RI called TECHE. TECHE is technology enabling children through innovation. And it would serve as the point of contact for people within CHEO, whether that's doctors or nurses or anyone really that wants to work on their idea, or outside companies that have things that they think might be useful for our patients, be that robots or AI, and don't know how to connect with doctors. So if we have at least a point of contact, we can start. This circle on the right looks kind of complicated, but I'll walk you through it very briefly, and then we'll go into an example. Is at the beginning, you're a doctor, you see a patient and you have an idea and you think, wow, we really should improve this. And then you kind of work on that idea. Maybe you prototype it, maybe you 3D print it, maybe you do whatever it is to kind of figure it out until you have a concept that you can test. And then you go through the R&D process. Once you finish the R&D, maybe you produce a paper, maybe you have a stable program, but maybe it goes on and it gets commercialized. And then after it gets commercialized, that company can grow and then get implemented back into the hospital. Now, there are in this ecosystem already things to help this wheel spin. So let's start with B. Many of you may remember the Hacking Health that we had. That's really to help you prototype and to think. And HIP 613 is all about thinking. But in and of itself, it can't do anything because you need the next steps. If we go to C here, this is where TECHE might fit in. It's helping people who are coming from outside companies to work with us and do R&D, or helping people who started their idea and want to take it through, get into and connect with companies for the purposes of commercialization. And A up here is things like the CAN Health Network, which you may or may not have heard about, but there is a big government announcement this afternoon for those of you that received that email about how CAN Health, which is really about implementation. How do you get new Canadian technology into hospitals and through the procurement? So you put all those things together and you really start to build this ecosystem, and knowing where you are on this map helps you understand where do you need to go next and who should you talk to. So with that in mind, I think we have an example of internal innovation over here, and I'll hand the floor over to Dayre, although Dayre, I'll drive for you. You just tell me where to go.
Thanks so much, Matt, and thanks for the invite. Before I jump in, I only have 5 to 7 minutes, and I just wanted to say that while I'm presenting, this isn't me. This is a really large group, and don't even have time to name all the organizations, let alone individuals that played a part in this. People from CHEO, the RI, the CRU, outside partners, Algonquin College, Hacking Health, Thistledown. So please keep in mind as I present this that this is in no way me. So with that said, at the beginning of the pandemic, there was a group of us here at CHEO recognized that there were going to be significant issues with personal protective equipment, particularly masks, and that they were going to be key to success during the pandemic, in particular with helping reduce transmission, and that universal masking was going to become a reality. It was already a reality in healthcare, but it was going to become a reality in the community. And that became our life. For those on the call, you seem to wear a mask most of your time. So if you can go forward, Matt. We also recognize that are you able to advance?
There we go.
We also recognize that when you solve one problem, you inadvertently often create a problem, or at least there's inefficiencies with the solution. And we recognize that there was going to be consequences to the environment with universal masking, and that a lot of the masks that were produced initially, particularly for community use, had significant functional or design problems that were making them inefficient. So I've shown some pictures here taken out front of the entrance at CHEO with masks piled up, and I'm sure others have had the experience of walking around and seeing masks on the ground, whether they be surgical masks or community masks. You know, I often clean up the garbage around my house, and there isn't a single time where I don't pick up a mask in the half kilometer on each side of my house. And then on the right side, I've got myself and my son Owen wearing some early generation masks, and you know, often poorly sized, poor filtration, high leakage, and you know, while still achieving some benefits, not doing everything they could. So we wondered if we could help solve this problem. Could you move forward, Matt? And so we set out to wonder if we could design a better mask, something that would achieve sort of the 5 Fs, which were made up by us, but just for remembrance. So high filtration or low penetration through the mask, something with good fit to limit leakage of air around the mask and into either the nose or the mouth. We were looking for something that was fun or comfortable, recognizing that people had a lot of choice and they weren't going to wear something that didn't work for them. We were looking for something that was friendly to the environment, and then ideally something that was fiscally responsible, not too expensive. And then the idea was to achieve this like triple bottom line, and that's you know, Richard Webster's line from CHEO's green team, but something that made sense financially, socially, and environmentally when it comes to decision making. We also recognize that at CHEO, although we could see the need and the problem, we didn't necessarily have all the skills and tools we needed to develop a solution or a product. So we partnered with some community or industry partners. So Eco Equitable, and it's an Ottawa charity that sews and manufactures, and then Dessous, a textile scientist from Calgary. And then we came up with a plan that involved sourcing and testing filters. And those filters needed to be something that were safe to be near an airway, and you know, had good filtration and didn't lose much performance following laundering. We needed to develop a prototype. We did some wear testing. CHEO was great, and you know, allowed us to do some wear testing and get input from healthcare providers and what they liked and didn't like and what they were looking for. We did some fit testing using the machines here at Ock Health to look at leakage, and then eventually to sort of try to implement and scale up. And I've got some pictures showing the second prototype or version there on the left, and then a picture of me doing some quantitative fit testing. If you advance forward, Matt. So you know, after a year, which as Matt said isn't that long, it was probably less than a year, truthfully, 6 or 7 months, we realized that we had a decent product, a product we were proud of. It had great filtration, so when new, it filtered out 80% of particles, and after 50 laundering still filtered out 70% of articles. That it had really good fit, 15% leakage, which was similar to what we were getting with surgical masks that most of you or some of you wear day in and day out. We had our sort of market survey here at CHEO, which demonstrated real high satisfaction with the mask, but areas for improvement in terms of additional sizes. And we were fortunate that the timing worked out reasonably well. And early in 2021, the American Standards for Testing Material came out with guidelines for consumer masks, and our mask exceeded those guidelines to the best of our understanding. So we were in a position where we could move forward. Can you push forward? So we decided we wanted to, knowing we had a product that we felt might help keep people safe in the community, and with wave 3, we were pretty confident wave 3 was going to come and be hard, that we wanted to get the mask out into the community so people could at least CHEO staff could protect themselves. So we walked through the process of getting approval and endorsement by CHEO. We worked on a name and called it the Ottawa mask. We had CHEO cons help us raise some awareness, and there was an article in the paper and a few radio shows. And then we developed a website on Eco Equitable's page for online sales, and we worked with a community partner, Cardish, for retail sales. And then we launched. If you can move forward, Matt. And things went well. So this is sort of my final slide, and just briefly outline some successes and some struggles. But you know, I think we had some successes with this initiative, where we were able to quite quickly develop a product that community wanted and a product the environment needed. And we've sold about 8,000 masks, which as you'll learn is much more than we prepared for. So some of our struggles with this project were, you know, we had a bit of a lag. We were pretty confident. We had a good product back in November, December, and it did take a while to figure out how to get this approved and to start making it available. There's no real clear process for how products are approved. We were navigating, while everyone was helpful, it was still challenging navigating between multiple groups at least 3 organizations, not mentioning our very wonderful and patient community partners. But no real means for a CHEO to sell and distribute a product like this, or potentially any product. Again, we were able to rely on community partners to make it work, and we did kind of fail through success. We, you know, due to limited money and some uncertainty, we only manufactured 1,000 masks pre-launch, and so 7,000 people had to wait between 1 and 3 weeks for their mask. I think the majority of those orders have been filled as of this week. I think there's we're down to a couple thousand. So because of that, we had to limit media promotion and further sales. So I will mention, just because I haven't up to now, that the sales were a fundraiser for CHEO. So money raised through the initiative was coming back to CHEO, not going into my hands or Matt's pockets or anyone else's. So anyways, that's the end. Happy to answer questions at the end. And Matt had mentioned a few quotes along the way, and I like this one along the bottom right. Says, "The reasonable man or woman adapts himself to the world. The unreasonable one persists in trying to adapt the world to him or her. Therefore, all progress depends upon the unreasonable individual." So I really do feel like when you innovate in research, that sometimes that's how you feel, that you're struggling against the way people presently see things, and need to just continue to be nicely unreasonable. Back to you, Matt.
Thank you. Thanks for that story. And I will vouch for Dayre's comment about himself, that he is an unreasonable person. And I mean that in the most pleasant of ways. But it's true, it's difficult. And I think, as Dayre said, it's a team effort, and you need to connect with a team to move these things forward. And there's always room for improvement, but I'm so proud of Dayre for having pushed this through and demonstrating that a physician at CHEO can come up with a research idea, do the research, partner with communities, and get something out and change the world, even to the tune of 8,000 or more people. Amazing. So with that in mind, we're going to move from an internal story like Dayre to an external story where our own Dr. McCormick is working with external partners to bring them in. And you can see how this is essentially all in the same cycle. It just depends on where you enter it. But either way, we hope that by building systems and teams around the physicians and around the members of our community who are doing these innovations, that we can really facilitate them. This is not about building a program as much as it is facilitating people who are already doing these great things. So with that in mind, Anna.
Good morning, everyone, and thank you. I'd like to start by saying that we have a wonderful but small research team that are involved in this space. I know Dr. Alazam, who started in our fellowship, is on the call looking at robotic walkers, and our very hardworking Sarah Zadie, who's our research coordinator. So thank you to the team. I would say I'd be amiss, however, if I didn't say that there are many hardworking therapists and staff working in this space, including augmentative communication specialists using eye gaze technology, our cochlear implant team, our complex seating team, our physiotherapists and occupational therapists who consider VR and virtual reality in treatment of patients. Next slide, please. But what is the problem? The problem is the fact that We know a lot of technology is out there that can really enable children. It can intensify rehab, it can improve function, and for administrators out there, yes, it can improve access. It can really improve the journey of a child who has a disability and their family. The problem is it takes too long from knowing that the device can be made to putting it into the hands of those who need it. Truly, it can be a lifetime of a child, and that's just too long. The other thing is that when you're on one of these journeys, and I have been with a few devices, sometimes at the end, you don't get the device you really need or want because you haven't been involved early enough in the process. Next slide, please. So I'm just going to highlight a few very quick pops of devices that we are either working on or our international partners are working on. So the Trexo I'm going to talk about later is a robotic walker that can now fit children from 2 to 12 who have severe physical needs for supporting and ambulation. Then the next, and this is left to right, top row to bottom row, if you want to use the arrow there, Matt. The second one is the Solo Walk that's been tested in larger individuals that have difficulty getting into a device because they've gained weight and they've become teenagers, and now it's being tested in the stroke population. But it has a lift built into the walker and it has servo control wheels. So if you give a little effort, it augments the effort. It can be driven by the therapist or it can be driven by the person who's using it. And we've collaborated with Carleton University in developing that. The next is an interesting app that we're looking at becoming more involved in, which for early speech delay recognition. And we have Dr. Miriam Mars, who's been looking at that with us as well. The next device is an upper extremity device for our plastic surgeons and OTs. Really, it's a robotic arm for people with very limited arm function. It can pick up even a small strawberry. If you look next, there are social robots that are working with children with autism. Next is another robot, but more working on physical exercise and demonstrating exercise post selective dorsal rhizotomy, where a lot of strengthening is required. Second row, there's a mixed reality VR system where you can use household items and a screen to work on upper extremity skills. And we now are working alongside our partners at Bloorview with the CIHR grant to look at that and bringing therapy into the home. There are apps for gait analysis. There are switches for Bluetooth access. There are immersive technologies for gait training and for pain treatment. Next slide, please. Our journey has included working with the Solo Walk, which I've discussed and started in 2015. Then the robotic gait trainer, which I'm going to show you. And we're ready to launch our crossover trial and delivering these devices actually into people's homes. So we're really excited about that. And thank you to the RI. We've had some support along the way for sure. The virtual reality we've started to work with, and we have a CIHR grant again, got a little delayed with COVID and our speech app work. Next. Okay, going to tell you a little bit about the Trexo because we're ready to launch our study. It's a Health Canada 1 device, so low risk device, wearable robotics at the hip and the knee, and it has a rift and base, which many of our therapists are used to working with. It has very precise control of hip and knee movement, and it can allow the patient to push off or multiple sizes down to 2 years of age. So we're marrying early diagnosis with intense repetitive therapy. In fact, our earliest user of this device went from about 25 steps per therapy session to 900 steps and moved heart rate into a moderate exercise range. We've published this result and we're very excited to be able to offer this opportunity and to study it more precisely as we launch the study. And I always like to listen to the family and the people are using. So we have a little video with a dad talking about the experience. We hope.
Technology allows us to develop new methods that can be very precise, and you can really kind of tweak it and get that repetitiveness in that can really tap into the the concept of neuroplasticity, which we know is real, and it can really help obtain that or maximize that potential in the kids. Specifically, it's allowing us to have him walk into school these days, whereas previously, even for appointments, whatever, we would need to bring him in a wagon or a chair. Now we can put him in the Trexel.
There's a longer clip for those of you who are more interested, for sure. But I will say, we started with the issue. The issue is how long it takes, and really making the technology to fit. So it takes a long time, and sometimes you don't get the good fit that you want. So what is our solution? Our solution is to be involved early and to have, to be known as a place where people can bring this technology, and to have a manager to look at if it's a good fit, if it's a good idea, and to really have the families at the center working with this well-oiled team that with great experience, our therapists, enlarge the team to include engineers, computer scientists, and really to get those devices quickly available to people to improve quality of life. I would say #best life. I'm done, I think, Matt.
Amazing. Thanks, Anna. What an inspiring story. I just love watching those kids work with those robots. And it's just, I'm so excited to see this kind of stuff moving forward. I think what's really neat is that, as I mentioned, these are two of CHEO's own, minds working towards this, but there's a number of others, things like solving supply chain issues in second and third world oxygen supply delivery systems using 3D printing. Super scalable, super low cost, and actually CHEO is at this very moment partnering with an organization to look at, can we 3D print parts for CHEO rather than having to order them from other countries, for example. We're working with the third largest manufacturer of hearing aids to build digital health into a hearing aid. So instead of having a Fitbit, you wear your hearing aid, and it can access things like your mood from how you talk, your heart rate through your ear, your blood pressure, your temperature, your breathing rate, your activity, how often you call your mother, all through your hearing aid. And it could really change the way we incorporate biometrics into our daily clinical life. Another of Dr. McNally's great projects, Inside Scope, for crowdsourcing systematic reviews, and a number of other clinicians, Lillian Lai, again with eMurmur as a iPhone or cell phone based auscultation. And so there's a ton of stuff going on, and we hope to scale and grow that to really facilitate it. So we hope that Techie, as you've been hearing, will help mostly with navigation. So I liken it to rumble strips on a highway. So rumble strips are very easily crossed bumps in the road, right? Super easy. But if you put enough of them one after the other, it brings you to a complete halt. And that's the purpose of a rumble strip, slow you down and stop you. But that's really not what we want to have happen in the innovation space. So having someone show you where to go and advocate for you and help you and mentor you during this, show you who to talk to so you don't spend all your time figuring out, well, I don't even know who to ask about this. Partnering you with clinicians, researchers, academics, government, families, whoever it is you need, whether it's business or funding, knowing where to connect to you. And then creating this ecosystem of support, encouragement, and enthusiasm to say, you know what, this is your job. If not the doctors coming up with, validating, and influencing how we build medical technology, who the heck else is supposed to do that? It's our job. We've just never really said it out loud before, but it is our job and we should be doing this. And so what we propose is this potential structure where on the left, we have the RI and CHEO doing the things that we already do. Clinical care, research, and ideation all happens in the places that exist. Similarly, external companies like ones that make robots or ones that make masks, they already exist. But the problem is how do they relate? So we propose that Techie be this organization in the middle, where some of the incubation, where the connections, the support, the development of the product, the development of the market, all happens in there. And then maybe you graduate out and you go on to an accelerator and you move on to create a company, but maybe you don't. And that's not the pathway for everyone. Maybe you work with these external partners, as Anna has been doing. Either way, at the end of the day, you end up with earlier adoption of this healthcare technology and technology that suits the needs of the patients better for your involvement. And so what we've been doing now is essentially this. We have a task force. We have some interim funding, which we're very grateful for from CHEO and the RI, and also from the U of O. We've been working on policy changes and creating some test cases like with Anna and Dayre there, and figuring out how best to support this kind of activity. We hope soon to move into phase 2, where our task force will move on to be either a program or a formal committee within the RI, where we work more with a couple of external organizations like Can Health, where they work with procurement and implementation, or KidsX, which is an international similar example of how do you get stuff into hospitals through procurement, working on stable funds from probably the federal level, and working on our team that supports the innovators. Eventually, we hope this to maybe become a separate entity within the RI, a bit like the CRU, but for innovation, where this is the place to go. We'll likely be doing that working with the university as they're building a regional innovation hub at the university level. So CHEO would have its own group within that. And I think what's interesting is this is not a CHEO unique problem. It is happening all across the country. And so we would eventually like to scale this as a national program for pediatric hospitals to support innovation across them. I have two more examples before we wrap up there. And one of them is my own experience, which began in 2005, actually. But I was working on innovation back then, doing something called DizzyFix. But in 2010, I started Shoebox, which is a hearing testing platform you've probably heard about before, and built a team around this. And it was actually super difficult. And it's one of the reasons I'm really passionate about making this change now, because I would like it to scale faster and quicker. And now Shoebox is testing somebody's hearing every 3 minutes around the world. We just passed 1.5 million tests, which was pretty exciting for us. And we're delivering, hearing healthcare at scale. This is our ambitious goal, is to test 1 billion people. And in March 18th, we were at 1.5 million, and we just passed, 1.4 million. Now we passed 1.5 million. And you can see the exponential growth curve over time. We opened up an online platform as well for hearing testing. So if ever anyone needs to access remote hearing screening, Shoebox Online is a free online hearing test, which has seen some great adoption over the past several months since it was introduced last year. And I'd just like to see that happen to all of our projects. And Shoebox now has a team of 100 people behind it working on that. So we think now is the time because each of the strategic plans of all of the organizations we're working with essentially has the word innovation in the title. And so it's time to, ask or maybe unreasonably demand that we turn that into a real thing. The innovation hub that I mentioned through the university is coming. CHEO's strategic plan is aligned around this, as is the RI's, as is some of our partners in the city at TOH and Bruyere. As such, we've spent the last 6 months talking to everybody we could get a hold of. And in case anyone knows anyone that we should talk to about this or could maybe help, please tell us. One of the great groups is actually led by Jason Berman's sister, Creative Destructive Labs in Toronto, which is a way of creating that ecosystem instantly, where you can connect with people who have done what you're looking at before and can help advise you about what decisions to make next. TAP is essentially Mars in Toronto rebranded. Can Health and Dante Mora has been mentoring us personally. The guy is so busy and he spends an hour every few weeks with us helping us through this, where this is for the procurement. KidsX is a accelerator essentially in the States that CHEO subscribes to. And if you're interested in bringing one of your ideas to this, they are recruiting over the summer and we'll be running it again starting in September. So please talk to us about that. Invest Ottawa, of course, Children's Healthcare Canada has been advocating nationally for this kind of work, working with the other hospitals below as well. And I just met this guy yesterday, and I'm going to give him the floor for just a minute. His name is Sean Mondell. He is a ER doc in Hamilton. And Sean, I don't know if you can either unmute or maybe turn your camera on if it's not on, and just comment on how this is not a unique problem to CHEO, and it is something that you guys have been experiencing in your organization and are keen on doing something similar.
Yeah, absolutely. Thanks, Matt. I'm hoping everybody can hear me. Yeah, as Matt said, I work at McMaster. I work at St. Joe's in the Hamilton area, and we're very much in the same position where we have a bunch of super clever, interesting individuals solving healthcare problems on a regular basis. And really the question is, how do you go from this idea of having people doing great things locally to an environment whereby the hospital, research institutes, local funding agencies are all aligned in a way to turn that into an early stage patient investment with minimal kind of effort and exertion on behalf of the creator. And so we're very much on the same journey. We're very much in the same place as what you guys have done. And what I will say is maybe make a last plea to all of those of you in the audience who are watching this and thinking, oh, this is really neat, but it's kind of like a fascinoma and I don't have ideas that would scale to this. You know, I would bring to mind that innovation is not only something that needs to come in the form of a product or a deliverable or something that sits in people's hands. Services and the way we think about care are also real innovations. And all of you spend enough time. The fact that you've showed up here today to learn about this tells me that you have that bone in your body that makes you think, you know, how can we do this better? And so, I mean, keep up the good work. We're very much on the same journey. I'm going to keep learning from this team and hopefully share my learnings broadly and know that a lot of us are on the same journey. It's a little bit of a race, but it's also a little bit of a kinship as we move forward.
Amazing. Thanks, Sean. I just love having other people, and that's why I brought you in. I'm so glad you joined us. It's so nice to hear what other people's experiences are. And as I mentioned, although this is a very local program at the moment, we are eyeing regional, provincial, and then national level programming that helps bring this and highlights this and connects the right people. Oops, I did not mean to do that. So that brings us near to the end, which is great because we have a little bit of time for questions. But I want to highlight, what is our ask? Why are you here? So you learned some stuff. We covered our objectives. Great. But I actually want some things from you. And the things that I want and hopefully end up helping you are that you know people that I don't know, that Dayre doesn't know, that Anna doesn't know, who can help us. I am astounded all of the time. So there's this thing called Grand Challenges Canada. They give you up to $1 million to deliver a program innovation that affects second and third world countries. The chief financial officer, David Brooke, is friends with Trevor Pound, who is Catherine Pound's husband. And so the fact that that very small circle puts me right into the leadership of Grand Challenges, I didn't know that until yesterday. And that's why I highlighted it right now. I got introduced yesterday. I'm having coffee with him virtually later today. That's what we need. We need us all to leverage our individual voices and connections to make this work. So if you think you have somebody that you know, friend, family, whatever connections, we'd like to know about it. Please connect. Jim Bottomley is the administrative lead on this, and I'm so grateful for all the work he's been doing. Amazing. Please reach out to him with that. Secondly, funding. Funding for this is often challenging. We have a kind of a phased approach for it, being that there's limited funding coming from the RI and CHEO. We are looking for stable grants and participants. So if you're good at that, you're a grant writer, you have a grant writer, you have a great idea, or maybe you know someone who is an influencer in that ecosystem, let us know, because we are in the process of setting up meetings with the federal minister in this region to talk about how to access some of that new biotech money that was announced in the budget recently. And lastly, we'll be leveraging the success of various projects and probably from an equity standpoint. If you're a CHEO graduate and want to donate a part of your equity back to CHEO, as Shoebox did, that would be great. Of course, your ideas and participation in this is essential, and your feedback. And I think just to highlight Dayre's comment on being unreasonable, I think it is time to say again out loud that taking 20 years to take known, stable, research-proven innovations to the bedside is ridiculous. We can do better than that. We should start to be unreasonable about that and demand that we do better about that. But it is a group effort. We need to go there together, and we need to be aligned in our vision and our participation. So there's challenges there, but it's time for us to do that. Because as you've heard from everybody who's thanked their teams so much, it's a team sport. This is an article from the New York Times. I dated it from my rounds the other day, but it's not from just recently. It's from about 5 years ago. Anyway, despite the enduring myth of the lone genius, innovation does not take place in isolation. Truly productive invention requires the meeting of minds from myriad perspectives, even if the innovators themselves don't always realize it. So not only am I asking for your involvement, but we need each other to do this, to make it work. And for those of you that have read Malcolm Gladwell's new book, The Bomber Mafia, he talks about how revolutions are birthed in conversation, argument, validation, and proximity. And that is what we need to create. We need to have a conversation about this. We need to talk about it. We need to be close to each other despite the pandemic and social distancing in order to make this successful. So with that, I'm going to finish. It's been a real pleasure to talk to you and share this with you. And I'm so excited about where this program is going and so grateful that we finally have a coordinated way of approaching this. So CHEO and Innovation, one team, and I'd like to open the floor to questions and comments.
So thank you very much to all of you. This is really very exciting work. I think tremendous work in the background by all of you, and it's wonderful to see the efforts in moving this forward. I just have a question for you, Matt. You indicated that Child Healthcare Canada is one of your partners, and I mean, there's been a lot of work done there in combination with the Pediatric Chairs of Canada around advocacy for pediatric issues in general, and lobbying government around pushing for support. And I just wonder to what extent that partnership is working to support your particular initiative.
Right. So great question. And I think it's because it's new, it's not always clear how particular organizations can help. They're often keen and say, how can we help? And not knowing what levers they have access to. So for the moment, what we've done with Children's Healthcare Canada is working on a national meeting. So they have run meetings involving all these stakeholders annually. And part of that meeting will be similar awareness gathering, like what we're doing now at the national level. And then they've offered also to help us create a pediatric innovation annual meeting as a separate, a standalone entity, if the buy-in from that sort of add-on has been good. And I think that primarily speaks to their strength, which is advocacy. And so it'll basically be knowledge sharing and connecting. So each children's hospital doesn't have to start from scratch, and we can learn from each other. I see a number of questions in the chat as well, but if anyone would like to speak up, feel free. Otherwise, I'm going to run through some of those.
Mostly comments congratulating you on your work. But
what are the biggest struggles? Anna Teresa, what are the biggest struggles? Yeah, there's so many there. I'm going to pin you. If you were to pick one, and Anna, maybe if you were to pick one, what are the biggest struggles you've encountered? And just to be clear, do we have till 9:30 or are we finished at 9:20?
No, 9:30. So Chris Fadaboncar has a question there. Chris, you want to pose your question?
Yeah, just wondering, I can see how, sorry, I'm going to back up. I can acknowledge how difficult it has been to support innovation for devices, but I wonder, are there other innovations that this group could promote that would be helpful? That the obvious money-making part of it is less obvious to me, but the innovation and the impact on children could be just as beneficial. I just wonder if that's something that's on your radar.
Yeah, I think one of the things that we've really been careful to highlight is that not all innovations are the same. And that's where we had sort of those internal and external or early or late innovators, depending on how you join. So are you the kind of person that brings in technology from the outside, whether that's a process or whether it's a device? or whether you're the type of person like Dayre who has made something that then goes out. So those are different. Interestingly, people like Melise Keys, she calls herself instead of an outside in or an inside out, she calls herself an inside in innovator. So she's really working on change within the hospital, particularly through EPIC and digital research in the EMR. So that is a different kind of innovation. We are certainly open to it. Because just the people we've had involved so far haven't been focused on that. We don't really have a comprehensive pathway, but if that's something you're interested in, we'd certainly be open to talking about. And Anna, I don't know, do you have want to comment on that? Or?
No, except for innovation is inclusive.
Yeah.
I would think that if you're thinking about a way to innovate, then connecting with one of our team, and if we don't know the answers, we're certainly willing to help people along their journey, and there's power in numbers. So if you have ideas, please share.
Thank you.
Dr. Lobos has a question around struggles encountered. AT, you want to ask your question?
Yeah, sure. Thank you guys so much for this very inspiring presentation. Obviously, the amazing things you guys have done came with some struggles, I'm sure. And I'm wondering if you could highlight what they were and how you overcame them.
Dayre, do you want to go first?
Sorry, did you say me?
Yeah.
Geez, that's hard. I'll be unreasonable in my answer. I think the thing that was the hardest, that in some ways is the cheapest to fix, is the culture. Where, like my research team had made me a t-shirt for my Christmas gift, and all it said on it was every step. And it feels like at every step you run into I would say a lack of culture around innovation and doing different things. You're allowed to innovate in this really tiny air bubble around the planet, and everything else seems risky or different. And then so it's the culture, Matt, and AT, and that in some ways is the hardest thing, but yet the least expensive thing to change. So innovation comes with some risk, yes, but it comes with benefit as well. So I would say it's changing that culture. And I don't want to give the impression that's unique to CHEO. It's
I think what's really interesting about that, and Anna, I'm going to give you the floor next, but just to comment on Dayre, if you're an innovator, you are by nature out front. And if you are out front in a crowd, you're standing out front alone. And being alone stinks. And I think Dayre's point is that being alone and feeling alone is not a great way to, although as a leader, that's to be expected. It's not encouraging. You run out of personal energy and enthusiasm more quickly. So if we can collect all the people out front and put them together, at least they will feel supported. And that's really one of the goals of this group, is to bring those people who are otherwise feeling alone and feeling like everything they do, every step is hard, and have us essentially our own peer support group. I think that's really helpful. The other thing I would say about communicating innovation is that everybody likes progress, but nobody likes change. And so everyone's excited about all these new robots and whatever else. I'm sorry, I keep on saying robots, but I just find it encapsulates it so well. Everyone's excited about it, but if you're changing what I do every day, I'm not so keen on that, because that sounds like a bunch of work for me if you're changing things. And so one of the keys to lowering the stress level of people talking to people about innovation is to make your innovation sound like something that you've already done, something that the hospital's already done. It's a bit like when we implemented, I don't know, some other thing. I was going to say Epic, but that's not necessarily a great feeling. But whenever we did something before, it's a bit like that. And so it's not such a stress, even if to you, it is a total mind shift, new way of doing things. As soon as you talk to the people who actually have to do that, I would try and tone it down a little bit and say, you know what, this is an iterative, sensible, slow progression to the next stage. Like it's, keep your exciting talking to yourself almost. Anna.
I have to say two things are the most frustrating. One are the road bumps, which you've talked about. is the time that it takes to start a project or to get that device in. I think the second thing, and we're working on that, everything from ethics to the RI, they've been really great to try to speed things up, because technology works fast, and that place work, you know, that space and the hospital space are so different that we've got to really change the way we're doing many things. I think the second thing is we do one thing and then another thing. We have to build this team of people, and that's their focus. In rehab, for example, the physio, the OT, you know, we have to have those tech teams, and we have to invite different people to be in those teams, like engineers and the family at the center. And that's what's going to speed it up, so we can do 10 projects at once, not one at a time. And if that's the change of culture that you're talking about, I'm all about it. Nothing I've ever done, I think Hannah said this, nothing I've ever done, I've done by myself. It's the team that's at the center of this. And we need to build these strong teams to bring this really innovative work to the family.
So Anna, maybe I could just comment on the issue, and Matt alluded to the issue, the whole concept of the accelerator, and the work that Dean Ferguson is doing in that area. And is that something that that you have tapped into at the University of Ottawa around essentially moving projects through in a quicker fashion to bring them to fruition? And that's something that they've really been working to advance.
Certainly, we are always looking to tighten the partnerships between us and the university. And so if that's something you could facilitate, that would be great. We haven't spoken at length, but sort of tangentially with the group at the U of O. But now that you've had a little more color as to what we're working on, honestly, that would be great if you want to just shoot us both an email and say, hey, I now understand a bit more about what we're doing, and I see how this aligns. I would love to hear more about that.
Okay, great.
Thank you so much. As a note on Anna's comment, and I think this is why Dayre says it's hard culturally, is there are 3 different groups. If you think of culture or spheres of operation, you know, there's the research sphere people talk about, there's the clinical care sphere, there's a business sphere. Each of those spheres has different cultures, and it's like traveling to another country. If you didn't know the customs of that country, like for example, you go to a business meeting and you start talking about patient-reported outcomes, they have no idea what you're talking about, and they don't care. You know, if you go to the business place and you start talking about ROI and venture capital and this and that, like, okay, yeah, I know what's going on. So if you are unprepared to go to the other sphere, you're lost. It's like being in another country. And I think bringing those disparate spheres together is the challenge that we are talking about. How do we talk to each other? How do we educate each other to speak the right language? And how do we navigate? Again, you go to another country without a map, you're lost. And so expecting that to be different, unfortunately, is a bit naive. And so really this group is sharing the experience that we all had being naive, trying to do that and being lost. And we really want to help everybody else avoid that situation and bring a map, bring some friends, bring a translator, and it will just go a lot better. So I hope we can do that for each other.
I just wonder, in relation to that, if Dayre might comment on the business aspect of getting things up and running vis-a-vis the masks and the production issue, and how that all sort of came to pass, and where the challenge arose around the projection or prediction of the model, you know, in terms of the business model.
I don't know that I can do that in 1 minute. Truthfully, yeah, I mean, I don't want to give the impression that anyone got this wrong. I mean, in terms of the projection, I mean, it was 2 things. We had some really good conversations between the RI and the CRU and Techie and CHEO and comms, and I mean, a whole bunch of factors come together. And part of it was what, you know, how many masks do we think we can move, or people are going to be interested in? And part of it is, well, there's upfront costs, and they're not small. Producing a high quality mask isn't cheap. And CHEO, I mean, to Matt's point, like CHEO isn't a venture capitalist. They're not someone you go to say, hey, will you invest in a product line? Will you put up tens of thousands or hundreds of thousands of dollars with the hopes we sell tens of thousands of these things? So we weren't sure how much uptake there was going to be. There was only a limited amount of money available through the RI and CHEO. So yeah, so we landed at 1,000 and decided to define that as a success. It turns out we probably could have sold 15, 20 at least, but that would have required hundreds of thousands of dollars up front. So challenging in that way. And then the other issue is that we had to make decisions around, well, how, it's great that we have a product and it's great that we have a way to make the masks, but how do we distribute them? Who takes the names, who takes the funds, who puts them in the packaging and mails them out? And I don't know, like maybe Jim or Matt could comment on that. Maybe we'll get to the point where we have that ability through a website. But in the end, we were very fortunate to have some really accommodating patient community and industry partners who were willing to say, hey, yeah, we can set this up on our website, and we've got a Shopify store, and yeah, we can get us some barcodes and we'll take them into our stores, eventually, and provide a way for people to pick them up. And it's very important to us that those community partners don't take a loss. And I don't know, I'm not really sure I'm answering your question other than there was a lot of things to sort out.
Of the challenges, and it's clearly not straightforward and simple. I guess we are out of time, and really wanted to thank you all for an excellent presentation, but also in highlighting this issue to everybody, and the opportunities that it affords, and hopefully it will garner more opportunities for partnering and bring more.
And thanks very much to all of you for the opportunity. And I just wanted to say, this is the beginning, not the end. It does not end with Grand Rounds. It is the beginning. So please make it an amazing start to this journey. Please contact us. I put Jim Bottomley's email in the chat. He's probably the first point of contact. Please reach out, share your resources. And Dr. Duffy, thank you for offering a connection to Dean Ferguson as well.
Sure.
Thanks, everybody.